My name is David Duncker. I'm head of the Hannover Heart Rhythm Center in Hanover, Germany, and today we will talk about guideline-directed management of patients at risk for sudden cardiac death. Well, sudden cardiac death remains a major threat to the population and the overall mortality in Western countries, so it is a major problem nowadays. And still, we saw incredible increases in heart failure medication, drug treatments, and we have now fantastic heart failure medications like ACE inhibitors, ARNIs, beta blockers, MR antagonists, and SGLT2 inhibitors. And all of these showed slight reductions even in sudden cardiac death and even sudden arrhythmic death. And of course, we reduced the impact of this, but still it remains a major problem nowadays. Well, the new guidelines, only recently published here at the ESC Congress, reinforce the common data and common recommendations on ICD therapy, which we know that works and is well established. And all of these different recommendations for ICD therapy need, of course, a heart failure patient, reduced ejection fraction, but also optimized medical therapy. And this is important because we first need to establish the medication and then reassess the risk of the patient. And for this, we need the time to have the patient in this term of risk stratification. And the new guidelines now also give a recommendation to consider WCD to protect the patient in this early phase of heart failure and therapy optimization. Risk stratification is a matter of time. It's not a single time point, but it's a period. And in this early phase of heart failure, in the moment after diagnosis, we first need to up-titrate the medications and really look for an optimal drug therapy. And in this phase, we showed in our data from Hannover in the PROLONG study and the PROLONG 2 study that we can protect the patient using a WCD because they have arrhythmic events and we can save them from sudden cardiac arrest. And we also see that we can, a lot of patients improve over time in EF, and EF is the only marker for risk stratification that we really have for the moment. And we can save the patients from implanting too early an ICD. We saw in our long-term data from the PROLONG 2 study that early WCD shocks were not a predictor for long-term mortality. So if we save the patient from an early sudden cardiac arrest, then his prognosis is the same as in a patient that didn't experience any arrhythmia.